The following podcast is part of a certified educational activity titled The Personalized Paradigm in CRC Care, Translating Emerging Evidence to Guide Therapy Selection in Advanced Disease. Access the entire activity and complete the post-test at peerview.com/UCS860. Downloadable slides and practice aids are also available.
Well, good evening, ladies and gentlemen, colleagues and friends. I'm really happy you're here tonight with us. I know it has been a long day at the meeting, so we want to make it easy and light and interactive. Along with my incredible colleagues, Dr. Lonardi from Padua and Dr. Strickler from Duke, we have incredible world expertise in the development and implementation of personalized medicine. We have a mixture of presentations of data, but also cases to make it very easy and entertaining. The theme from tonight is really the personalized paradigm in the care of colorectal cancer. So our goals for today is really to enhance your knowledge of the latest guideline updates, safety, efficacy findings from clinical trials for metastatic colorectal cancer, and equip you with skills to formulate tailored treatment plans that consider molecular findings, clinical trial updates, and practice guidelines in the context of a multidisciplinary team. And we want to provide you with tools to address aspects of care with systemic therapies, including coordination of care, management of treatment-related adverse events, and patient education. This is our agenda for today. We already are doing the welcome introduction. We will have a masterclass prep on the colon cancer with MSI High. We will do practicum sessions, and we look for particularly repairing mismatch strategies in colon cancer, and we're taking aim at metastatic colon cancer, integrating personalized approaches with targeted platforms in sequential lines of treatment. Some of these data are practice changing, and it's important to be aware, and not only to be aware at what line of treatment you should use it. I think we all know we need molecular profiling to make the best treatment decisions. But the reality is that many of these patients are not getting profiled in first line. And when you look here at the slide with all the data, that only half of patients are not receiving biomarker-driven treatments in the first line. Even in second line, it's pretty low. And there are a lot of different reasons, access, but also the time it takes. And we can talk about a little bit how we deal with these challenges. So the really most important take-home message, do the testing as soon as you can. And we tell you what tricks we use to get it in time for newly diagnosed metastatic colon cancer. Now, molecular marker is one way to predict treatment efficacy. The other one is the primary tumor location. And this has actually come out of our group at USC, where we found that biomarkers were different between the right and left. And when we looked for the location, there were no data available in any clinical trials. So we had to go back to 2000 charts in order to get the tumor location, because no one ever recorded it. And we now know that location is highly prognostic. The right, the median survival is half than the left. And we know on the right side, the EGF receptor do not work. Now, very interesting, and that is new data. The worst tumor is not the cecum, but it's really the hepatic flexure. And almost the best one is the splenic flexure. Now, what we also learned, the tumors in the transversus colon are much less frequent, much less frequent than the ascending and the ascending colon cancer. And no one knows why. So there is a lot of room we still need to learn. Now, these are the markers you need to test before you make any treatment decisions, because we have effective treatments changing significantly the outcome of this patient population. We all know about VAS mutation, and we hear from Dr. Lonardi the newest development on specific KRAS mutations. We all know about BRAF mutation. We will hear more where we are with the new breakwater data. I will talk a little bit about the mismatch repair. There is a change in standard of care coming, and we all heard about the HER2-directed treatment, which makes a huge impact on overall survival. So the MSI is certainly a very important marker to do. And you know, this is paradigm changing for rectal cancer. We don't do any more radiation, no any more surgery for MSI rectal cancer. Big difference. And this is now spilling over not only for MSI high, but for MSS. So there will be a change coming the next couple of years where we will do much less surgery, or certainly more sphincter-sparing surgery, but maybe replacing it. There are now talks, maybe doing it for colon cancer, which is more difficult to monitor. But we will experience the next couple of years a change in the neoadjuvant approach. Now, MSI high, there is no excuse you don't do it, because you can do immunohistochemistry. Every pathology lab in a hospital can do it, and you get it the next day. Now, most of us do NGS testing because we get not only the mismatch repair and the MSI high status, but we get also the KRAS and the BRAF and all these different markers, which may be very helpful. PCR is almost not used anymore. It's really replaced with IHC and the NGS. If you need a quick test, your pathologist can stain it and you will know if it's MSI high or not. Because the NGS takes, as you know, 2 to 3 weeks. What we do, and would like to know later on from both of them, we do a liquid biopsy because we get it back in a week. That's the next thing, because we not only test the tumor, we also test the blood for circulating tumor DNA. And it's a little bit a confusing slide, but it gives you an idea. At the moment, the major application is circulating tumor DNA, but that's not all of it. You will see tests develop in the next couple of years, which look at not only circulating tumor cells, where you can do single cell, but the exosomes with RNA packaged in to really inform the metastatic niches. You can see methylated DNA, which is maybe more sensitive than circulating tumor DNA. So there are a lot of new tests developed which will come our way. Right now, the most used is really the circulating DNA, and I will not go into the MRD versus the NGS testing, but because it's metastatic disease, usually it's an NGS-based test where you know exactly the mutation. So if you have a big clinic, that is helpful to download. This is information for the patients with a lot of access to patient navigators, information on precision oncology, group chats with other patients who can help each other. So this is a very helpful resource you might take advantage of. Okay, now this is the first case. So you can see this is Matthew, a 58-year-old patient presenting with newly diagnosed cecal colon cancer with mets to the liver. And you can see here the laboratory results, nothing outstanding, maybe a little bit anemic, but nothing. So what do we do? What is the first step? How do we approach the baseline assessment? What biomarkers we would test? So Sarah and Sean, tell me what you would do and what are the first steps? What do you need to consider? And so on.
So, working at an academic medical center, maybe I'll stand here for you here. The very first thing I want to know when somebody comes in with a right-sided colon cancer like this is their MSI status, because everything changes for that patient based on whether that tumor is microsatellite stable or MSI high. So certainly at our institution, we would favor some type of NGS test, but I need a result quickly, right? Because we know MSI high is highly actionable very quickly. So I personally like a liquid biopsy to get the quickest possible answer, though it would not be wrong to do a mismatch repair IHC to get a quick answer as well. But then also at the same time, I'm thinking about, does this patient have potentially resectable disease? If they have microsatellite stable, we like to get our surgeons involved to look at those scans with us just to get a sense for what the extent of the patient's options are. But I think the key takeaway here is biomarker testing out of the gate with a real focus on mismatch repair first.
Sarah, What do you
Yes,
think?
I completely agree with John. In Italy, we have the universal screening for Lynch syndrome, and so the immunohistochemistry for MMR protein is part of the initial diagnosis, and so probably I would receive this information in the diagnostic report of the biopsy of the colon. I would expect that. I have to say that also, we say that Italy is thin and long, and so not everywhere it is the same, but basically the guidelines are strongly support universal screening in every stage of colon cancer, colorectal cancer, and so even if you have a surgery specimen or if you have a liver biopsy, you should receive the report with this information.
Very good.
And I think that in this specific case, you know that microsatellite instability is more frequent in the right side of the colon, and 58-year-old is not super young, but still young. And
It's
so
super young, okay?
it's super young. So I think that the probability to have an unstable colon cancer is not negligible.
And do you do then, since you're doing immunohistochemistry, do you do NGS then at the same time, or how do you get the other markers?
Well, usually you have immunohistochemistry as universal screening, and then if you have a deficient MMR status, you have a confirmation with PCR mainly. And then you have a parallel NGS, a small panel, not a comprehensive genome profiling, but a 55 genes panel for the clinical practice, including all the relevant genes.
Okay.
And also because clearly to know the BRAF status is important to decide if it is a sporadic tumor or if you can have a Lynch syndrome. And so we ask for both information.
That's a very good point. And I think not everyone has the big panel with the big companies, but some have a really targeted panel, which usually addresses all the important genes. Okay, so let's move on. This is your first question. Which of the following molecular profiling tests would you now perform for a patient with newly diagnosed metastatic colorectal cancer? 1, 2, 3, 4, 5. Okay. Actually, the only wrong answer is at the end. Okay, you can do a lot of different things. Immunohistochemistry is usually, as you heard, the fastest, NGS the most comprehensive. You could do PCR, usually as confirmation for immunohistochemistry, but not alone standing. So there is no wrong. The most important thing, do the testing. Okay. So let me talk a little bit about the mismatch repair deficient tumors and treatment organization. I think we all know immune checkpoint inhibitors, and we all know when you have PD-1 or PD-L1, you basically inactivate the T cells. And when we have antibodies against either the L1 or the PD-1, you actually prevent blocking the inactivation of the T cells, and it stays activated and potentially can recognize the tumor cell. Based on many data, and we present some of them tonight, there are approved guidelines with approved immune checkpoint inhibitor. There is the dostarlimab, the nivolumab plus minus ipilimumab, and the pembrolizumab, okay? And these patients are monitored, and depending how effective it is, and as you know, immunotherapy is a very unique treatment because if it works, it continues to work. In other words, if stable disease or partial response, it can last for a very long time. Now, if you get eventually progression of disease or you have innate resistance, and that's very important to know, that the innate resistance is higher in the monotherapy compared to the combination treatment. So that's one of the differences. Then you can switch to chemo. Now, you also need to know MSI-high tumors are highly resistant to chemo. The median survival when you give chemo in an MSI tumor is 12 to 14 months. Okay, it's like a BRAF mutant. Okay, so don't give chemo. Okay, give the immunotherapy. There are different ways you can get microsatellite high status. One, of course, is Lynch, a germline. The other one is a somatic mutation. Or you can have even a hypermethylation of the MLH promoter. And that's usually when you have an MSI high tumor, or that you will really do a reflex for the methylation of the epigenetic silencing. And we talked about the testing already. Now, will that matter on the efficacy? So far, we don't think so. But what makes a big difference potentially is we look at all tumor mutational burden, as you know. In the US, TMB of over 10, you have pembrolizumab approved. But for MSI high tumors, there is also a potential cutoff. Everything above 40 does much better with immunotherapy. Okay, either with Nivo or Nivo EP. So there are not all MSI high are the same. So the first breakthrough was Keynote 177. You remember it was pembrolizumab versus chemo in metastatic first-line colon cancer MSI high, and that was locally tested. And there was so much discussion about that the curves were kind of crossing and the chemo was better in the beginning. This is all caused by misclassification. It's nothing to do more sensitive and higher, and who are these patients? These are the patients who are MSS, not MSI high, okay? Because when you essentially confirm, the curve don't cross anymore. But it was very clear in this patient population, pembrolizumab was superior to chemo. No surprise, huh? And the hazard ratio was around 0.6, sometimes it's 0.59, sometimes 0.61, but it's about 0.6. Now, what is very important for you to know, and that becomes more and more clear, is PFS2. What does that mean? It means the subsequent treatment. When you start chemo followed by immuno, or you start immuno followed by chemo, it's different. Because after immunotherapy, the chemotherapy seems to work better. Sequence of treatments matter. Not the efficacy of immunotherapy. It almost doesn't matter when you give it. But the chemotherapy sequence matters. And you see that also in the Checkmate 8HW. And there are many data coming out of Japan after Nivo, much better treatment in gastric cancer with Taxol or irinotecan. So when you do immuno, it changes the tumor microenvironment, and your chemo will work better. Okay, just keep that in mind. So sequence matters. You cannot make it up later. Okay. Obviously, overall survival was not as good because 60% of the patients crossed over, so forget about this. It was all about PFS because here you get the benefit of the immunotherapy in second-line treatment. Okay. Now, I am heavily biased because I'm a big CTLA-4 believer like Sarah we are, because we were involved in the first Nivo EP trial, which we published a couple of years ago. The efficacy is just higher. But there was never a direct comparison between Nivo EP versus Nivo. We have here in this graph, which I think is fascinating, you can see the chemo part in Keynote and in the 8HW. And you see the Nivo EP arm of the 8HW, and you see the pembro alone. Now, you would be expecting that Nivo is very similar to pembro. All the data show very similar response rate. So tomorrow at 1 o'clock, Dr. Andre Thierry will actually show the data of the direct comparison, first one ever done. And you will see if we are right with our assumption that Nivo EP is significantly superior when you assume pembro is very similar to Nivo, which is a reasonable assumption to do. So this was the study, and it was in all lines of treatment. Okay, so there is a 2-to-1 randomization. It had a Nivo alone arm, the combination arm, and chemo. Chemo was only 1 out of the 5. And this accepted patients with locally tested microsatellite status. Okay. And this was presented exactly a year ago here for the first time. You see the chemo on the bottom with the orange, and you see the Nivo EP. And the curves are unbelievable. Or this is what we not used in colon cancer with a hazard ratio of 0.28, almost 80% improvement of PFS. And here, Central confirmed there is no crossover. These are the same. And then after the first CT scan, there are sustained separation of the curves. And look at this, the 2-year PFS rate is 72 versus 14%. And tomorrow we will see the Nivo alone arm, and let's see where it fits in. We assume it acts like the Pembro, which would be in the middle of the two curves. Now, this is again very important. Remember, I already saw the keynote, the PFS2. This is the difference. When you start Nivo IPI and you give chemo, it works completely different than when you start chemo and you give Nivo IPI. The same treatment, the sequence matters. So think about it. And I think it also matters for MSS when patients are on a clinical trial with immune checkpoint inhibitor. I don't know your experience. Any treatment we give after that seems to work better. There are no controlled studies, but many data in the literature. I think everyone who used immunotherapy is very familiar with the side effects. And astonishing, when you look at the Nivo IPI arm, 23% had grade 3 or 4 toxicity compared to 48% with chemo. Chemo is more toxic. It has just more side effects. Now, with immuno, you have very unique side effects which you need to watch out for, and we will go a little bit into it. And you can see the most common for immuno treatment related is skin itching. Often you don't see anything, but the patients say this is itching. They have diarrhea and the thyroiditis. Hypo or hyper, so both can happen. And for the chemo, you know all these side effects. So quality of life is very important. I couldn't understand the graph. Believe me, the patients who get Nivo IPI do much better. They respond better, they live longer, their quality of life is much better. The only weird thing was with the fatigue more in the Nivo IPI, which I barely understand. Okay, so these patients, when you start and they're heavily symptomatic first line, and you see them after 3 weeks, you almost don't recognize them anymore. They're actually doing so much better. Okay. Just to let you know what's going on, this is the SWOG 1610 trial, or COMMIT, and this is a randomized trial where you do atezo alone versus atezo in combination with folfoxavastin, okay, or bevacizumab, shouldn't say that, bevacizumab and folfox, okay. So these data are generated, the role of the chemo in combination with immunocheckpoint inhibitors in first-line metastatic disease. But how much better can you get than Nivo IPI? Okay, so that's what will be interesting to see. Okay, so let's go back to Matthew's case. So we saw in the analysis that there was a confirmed mismatch preferred deficiency, MSI high. And you can see he was in very good shape, this very young guy. So the question was, additional testing showed wild-type RAS and BRAF. You need to be aware, BRAF mutant, 1/3 is MSI high. But forget about BRAF, just treat the MSI high. There was no HER2 amplification. So, Sarah and Sean, what do we do?
You want me to start? Yeah, certainly. I know you're a true believer, evangelical about Ipi-Nivo since your early days with Checkmate 142. But I had concerns about the additive toxicity, about how much more toxicity you get, and do we know that's really going to help the patients in the long run? With the data that's come out in the last year, I have been a convert. You've succeeded, Heinz. So I'm increasingly using that Ipi-Nivo combo in a case of a patient with MMR deficient or MSI high disease. I do think it gives the patient the best long-term chance for survival. And let's be honest, these patients are cured.
Yes, no surgery.
Yeah, they don't need to go to surgery. When they respond, the responses are durable. And, we have seen miracles in our clinics with that regimen. And while the toxicity is real and something we need to be alert to and be mindful of and surround ourselves with experts who can help us manage that toxicity, I think it is the right thing for the patient.
Sarah, tell him it's not toxic.
It's I think that the additional toxicity is very low because it's important to underline that we are using ipilimumab only 4 doses at 1 milligram. It's not like the first trial in other disease with 3 milligrams of
Every 3 weeks.
ipilimumab.
Yes.
And it's completely different. And also in colon cancer trial, the CheckMate 142 and now the CheckMate 8HW, ipilimumab is used like a booster at the beginning of the treatment, only 4 doses, and then you continue with the nivolumab alone. And so I think that the additional toxicity is completely manageable. In fact, we had 23% of grade 3-4 toxicity, and if I remember well, in the Keynote 177, it was 22% with pembrolizumab.
Yes.
And so obviously it's a cross-trial comparison and blah, blah, blah. But, I don't think we have too much additional toxicity. And so the press release was already out. And so we know that tomorrow we are going to see positive results for the doublet. But, I think that for me, the standard now is the doublet. When I can consider to give a monotherapy in very selected cases, I don't know, if you have a cancer in a person with previously Crohn's disease, something like this, I don't want to deny immune therapy, but I am a bit cautious. And so I do prefer to give pembro or nivo because I don't want to elicitate too much autoimmunity. But I think that really they are very selected cases.
I couldn't agree more with you because that's very important. All of us who lived through the melanoma trials with 3 milligrams every 3 weeks, almost every patient was admitted with colitis. It was like the wards were full. That's not the same anymore. There are no admissions. There are very frequent colitis.
At the beginning in my institute, when they started to use in the melanoma, we activate a specific on-call shift for ipilimumab toxicity. Everybody was so scared.
Exactly. Now, the other thing is what is very important, and Sarah was part of that first trial. We had big volume disease, and we started nivo-ipi, and the tumor was shrinking, but it stopped shrinking. So there was still liver lesion, and I didn't know what to do. What we learn is if there is a tumor left and it's resectable, we take it out. So we took it out, and it was completely gone. So I think we learn more and more. Some tumors just disappear, but you have also tumors which kind of get fibrotic, and there is no cancer left. So I took a little bit back the aggressive surgical intervention in these patients because you can wait and you don't necessarily need to jump on surgery. But I got nervous. I want to get it out. But what's wrong?
Can I only add one thing? Because we mentioned Lynch syndrome. And in this case, we have BRAF wild type tumor and loss of MLH1.
Yes.
And so in our flow chart for the Lynch syndrome screening, if we find a BRAF wild type, then we perform an MLH1 methylation test.
Absolutely. Mm-hmm.
And if you don't have MLH1 methylation, you need to perform the genomic assessment for MLH1 because the suspect for a Lynch syndrome is really high.
Yeah, no, absolutely. And I think in the US, more and more, we do routinely germline testing in patients with colon cancer because it has significant impact, particularly when there's family history. So always take the family history to make sure you have identified a potential hereditary form of cancer. Okay, we have a question for you again. 58-year-old patient with newly diagnosed metastatic colon cancer, MSI high, presents with a very good performance status. Assuming the patient expresses pursuing aggressive treatment, what would you select as initial treatment? And you can see all the different combination of immune checkpoint inhibitor, CTLA-4, chemo combination. Okay, I think you clearly heard us. Nivo-ipi is becoming the new standard of care for these patients, and there is not too much to worry about the toxicity. Let's go to the Keynote 164. This is a little bit confusing, so bear with me. This is testing the efficacy of pembro in 2 cohorts who have differences in the number of lines of prior treatment. Okay, you see B more than 1 and the other more than equal 2. So they have just different pre-treatment lines of treatment. And the question is, will Bepempo have different efficacies? And it doesn't. Okay, so I think the immunotherapy really remains its efficacy to lines of treatment, but the line of treatment matters when you do the immunotherapy, which is much better when you start early as you can, followed by chemotherapy. This is the study Sarah already referred, Checkmate 142. It's in first and in second line. This is a second line, and you can see the survival and progression-free survival are amazing in metastatic disease who failed, I think this is the refractory, at least 1 or 2 lines of treatment. So this is another immune checkpoint inhibitor, the dostarlimab, and you can see that in MSI high. You can see the green arrows on the swimmer plot. They're all still on treatment. A hallmark for immunotherapy. If you respond, they're on for a long time. In many trials, the duration of response is not reached. Here, the response rate in the refractory setting was about 36%. Very consistent with Nivo-Ipi. It's between 30 and 50, depending on the patient population. These are the most common side effects. We talked about the skin changes. They have often itching and the involvement of the thyroid, hypo or hyper. So check that regularly. Colitis, I don't think it's 10 to 30%. I'm not sure where this is coming from, but it can do. It's probably all grades of colitis. That's possible. And of course, you look for liver function and kidney and lung and so on. But it's easy, manageable. I don't want you to read it. It's important when you have an immune-related side effect, look for the grading, because that dictates if you have to give steroids or infliximab, how long and what you have to do. This is beyond tonight's thing, but be aware of it. I think it's very helpful. The ones who have used it, it's pretty straightforward. But if you don't, there are very good guidelines to follow. So we're going back to Matthew. So the management of the immune-related adverse events. And you can see we started Nivo-Ipi, and the patients reported that he was tired, lethargic, and very cold at time. And the workup revealed TSH level of 12, I guess that's low, and low FT4 level. So how do you manage that?
So I think this is a really important point, and it speaks to what to look out for. This patient has an endocrinopathy, right? And he's had hypothyroidism. So I think it's very important, number one, to educate the patient in advance about what to expect and what the risks are of a therapy. So I tell my patients these therapies can cause anything that ends in the word itis, right? And this one, hypothyroidism or thyroid abnormalities, are some of the more common adverse events. So number one, the patient recognizing what's going on, reaching out to us. Number two, us having a multidisciplinary team around us to bring in rapidly to help. So at my institution, I think many high-volume institutions, we have access to endocrinologists whose only job is to manage endocrinopathies from immunotherapy. Now, that is wonderful for me because I can send it over to them and they have a treatment plan in place very quickly, and we can get the patient assistance quickly. But if you're in a center where you don't have access to these dedicated specialists, I would say that's something to invest your time in, to figure out how to access those resources quickly, because we would not want medical oncologists to feel like they need to be the endocrinologist as well. But yeah, that's...
Sarah, what do you do? And, that's a good point, because there are variations when you have colitis. Do you stop the IPI? Because I think that's a very important point.
Obviously, first thing is start corticosteroid. And but endocrinopathy are the only long-lasting side effects of immune therapy. We are not scared more about other toxicities because usually they recover very fast with the corticosteroids. And but when you have an endocrinopathy, you really you need to manage the acute presentation but then you need to manage the long-term supplementation. And so we manage the acute part of the toxicity and ask for help, like John, to manage the long-term toxicity.
Yeah, I think it's very important to know that all these endocrine side effects are reversible except one, which is the hypophysitis.
Exactly.
That is lifelong. It's a very rare event, but it is an impactful side effect you need to be aware of. Now, interestingly, some of the antibodies, the new CTL4, they will change the complement binding. And when you do that, there is not any more hypophysitis. So some of the new engineered CTL4 antibodies, you will not see a hypophysitis. Okay, thank you very much. This is the end of my part. The summary and the key home messages are: obtain your biomarkers. I hope I made clear, make sure that you have the key elements. We hear about KRAS and BRAF and HER2, but MSI is a big one. Do it on every patient. That should be standard. You also heard the first treatment for this patient is or has to be immunotherapy. And I agree with Sarah and Sean, it should be nivo-ipi. There are exceptions to the rule, and Sarah mentioned them, but usually this is an easy treatment with an incredible high chance of efficacy and cure. And make sure these patients are monitored, and usually side effects are very manageable. And if they have Lynch, you follow all the guidelines to make sure they are monitored correctly, particularly when they stop treatment and are cured, that they don't develop another primary tumor somewhere else. So thank you very much. And I think this is time to introduce Dr. Strickler and Dr. Lonardi, who take over the second masterclass to look at the personalized approach with using different targets. So I don't know who's first. I'll let you have it.
I was hoping I would not have to follow you. That was a brilliant job, and I will fail in comparison. But I have the task first about selecting treatment in the presence of a KRAS G12C mutation. And so with that, I think, first of all, just laying out the landscape, the mutational landscape of colorectal cancer. We think about, when I was a fellow, I used to go to the lung cancer talks, and I was always admired their pie charts where everything fit neatly and there was no overlap. In colorectal cancer, it overlaps all the time. We see KRAS mutations together with many other potentially actionable alterations. For example, KRAS could overlap with HER2. It could overlap with MSI high. Doesn't overlap so much with BRAF. At least that one stays clean. Yeah. But it's just important to know that you could have multiple actionable biomarkers in the same patient, and that's something that you might have to have a strategy for. So the first actionable KRAS mutation for us was KRAS G12C, and this was a major breakthrough. I was always taught, as I'm sure you all were taught, that KRAS is an undruggable target, and there's no hope that we will ever design a drug that can shut this mutated protein down. KRAS G12C was the first one that we developed targeted therapies for, and it's not an accident. KRAS G12C inhibitors take advantage of this intrinsic cycling between the on state, which is so-called GTP bound, and the off state, which is the GDP bound state. And these KRAS G12C inhibitors are uniquely capable of locking KRAS G12C in the off position. Additionally, because it's cysteine, it forms a covalent bond more readily, which also is better for medicinal chemistry. What I really love about targeting KRAS is that there's KRAS G12C is that it really is highly specific for KRAS G12C. And you don't have so much targeting of a wild type protein, which dramatically improves the tolerability. I've told this story a few times, but it really tells you about the tolerability of these therapies. I had a patient who was taking sotorasib, which is a KRAS G12C inhibitor, and she called me up on a Saturday at 4 p.m. because her dog had eaten her bottle of sotorasib, and she was terrified.
Oh my God.
Is my dog going to die? And I said, no, that's about the safest thing that dog could have eaten, because it really is very specific to KRAS G12C. It really doesn't target wild type proteins. So that's the one that you would want your dog to eat. It's safe, and this dog did fine. So I said KRAS G12C is the first actual target. That's good and bad. It's good in that we finally have an option for these patients with colorectal cancer. It's bad because it's actually relatively rare in colon cancer. It's about 3%. Really, the big targets for colon cancer up top in the top three, G12D and G12V. I would love to get more options for those patients. And then, of course, G13D. But there are many others that we find quite commonly in our clinic. So one of the first things we learned, and I don't think this was a surprise to any of us who treat colorectal cancer for a living and do research in this space, we probably expected this because maybe we're nihilists, gluttons for punishment, but we knew that probably you would need more than just monotherapy KRAS G12C for colon cancer, and that's in fact what we found. We did see that KRAS G12C inhibitors have activity. There are responses. We see it with adagrasib, divarasib, and sotorasib as shown here, response rates 10 to 29%. The problem is the durability of the response, the rapid outgrowth of resistance. And that was an early challenge that we recognized. Very nice work published by Mark Awad in New England Journal, where he looked at the drug adagrasib, that KRAS G12C inhibitor, to try to understand what happens to these tumors when they acquire resistance. He looked at 38 patients treated with adagrasib, single agent. 27 of these patients had lung cancer, 10 with colon cancer. He had pre and post biopsies to really identify what's happening at the time of resistance genomically. And I've put a box around the colon cancer group. Most of the patients develop some kind of acquired genomic alteration, and you can see that the biology of resistance in colon cancer is different from lung cancer. These patients will develop multiple concurrent genomic alterations at the time of resistance, unlike lung cancer, which will sometimes just develop solitary alterations. What's interesting is the diversity of these mutations and these alterations. You can see acquired KRAS G12D and R and V mutations, but then there will be novel mutations that haven't been well described yet, together with even fusions in this, all together in the same patient sometimes. That is a major challenge for targeting resistance. Additionally, this is a story that we first saw with BRAF, which I'm sure you'll bring up, but the exact same thing happened with targeting KRAS G12C that will be described in BRAF, and that is when you take a drug and shut down that mutated protein in the MAP kinase pathway, in this case KRAS G12C, it actually relieves the feedback reactivation of the receptor tyrosine kinases. So it actually upregulates the receptor tyrosine kinase at the top of the MAP kinase cascade, thereby driving signaling down wild type NRAS and HRAS to kind of restore the function of the pathway. So these cancers are built to survive single agent KRAS inhibition. And that also is a challenge that we needed to overcome and really provides a rationale to say we've got to hit this pathway in two places. And that's so we know we've got a lot of challenges. We need better therapies to do better in colon cancer. We need new mechanisms of action. And then most importantly, I think we need therapeutic combinations. And that first therapeutic combination to enter the clinic was the KRAS EGFR combination. Shown here in this table are 4 different KRAS G12C inhibitors together with an anti-EGFR antibody. And we can see here response rates are improved with these doublets. Progression-free survival also improved. And I'm going to go into specifics on our FDA-approved options here. So let's start with adagrasib and cetuximab, just alphabetically. Here in this publication that led to its FDA approval, we see about a 34% response rate, PFS nearly 7 months, and overall survival 16 months. This is a very heavily pretreated group of patients that do poorly with standard of care therapies. This was FDA approved in June of 2024, so it's an exciting development for us, and that's the adagrasib cetuximab combination. Now, in general, these therapies are well tolerated. I told the anecdote, but most of us find that typically when you see side effects, it would be in the grade 1, 2, mild to moderate range, nausea, vomiting, diarrhea. Rarely does it escalate to the point where you need to discontinue that treatment due to an adverse event. In this data, at least 29% of patients had a dose reduction of adagrasib. Now, as said, there's another recent approval. So just approved January 16th, not too long ago, sotorasib and panitumumab. And this combination was FDA approved based on the so-called phase 3 CodeBreak 300 trial. This took patients, once again, with refractory colon cancer. This is a group of patients that do poorly with standard of care therapy, randomized them to a high dose of sotorasib with panitumumab, a low dose of sotorasib with panitumumab, or just investigator choice, standard of care. And as we can see here, response rate was 26%, progression-free survival at 5.6 months. So this was FDA approved based on that data as well. Once again, what I love about this regimen is the tolerability. Most of the toxicity of this combo actually comes from the FDA-approved partner drug, the EGFR antibody. That's the dermatitis, the skin rash that you get with panitumumab. Once again, rarely do we see treatment-related adverse events that will lead to treatment discontinuation. In this data, only one patient discontinued sotorasib due to an adverse event. So next, where do we go from here? What's next on the horizon for colon cancer, at least with a KRAS G12C mutation? I think where we see the world moving is to bring these therapies up front. This is a pattern we've seen over and over again. Treatment works in the refractory setting, bring it up front, maybe even with chemotherapy. That's the logic behind the so-called CodeBreak 301 study, which we have open at our site. Not sure if you have it at yours, but this is FOLFIRI, sotorasib, and panitumumab. Takes patients with a KRAS G12C mutation who've never been treated before for their metastatic disease and randomizes them to either standard treatment, FOLFIRI-Bev, or FOLFIRI, panitumumab, sotorasib. Primary endpoint here is progression-free survival. So I think we look forward to seeing, this will take many years, I think, to complete enrollment, but look forward to seeing that data. Additionally, while this is not a first-line trial, we've got Crystal 10 on the horizon. This one has been open for quite a while. I think this one's completed enrollment.
I think so.
Yeah. So we may be seeing results from this soon. This is the adagrasib cetuximab combination in the second line, randomized versus standard of care chemotherapy. And this one could be quite interesting. This is a dual endpoint of PFS and OS as well. So I said KRAS G12C, it's exciting. We can finally drug the undruggable target, but we know to make a meaningful difference for these patients, we have to go beyond KRAS G12C to the other KRAS variants. And I could probably talk another 20 minutes about all the ways we're doing this, but I'll just give a little bit of an overview of where we're headed here. There are a lot of different types of drugs targeting these other KRAS variants that are now entering the clinic. The medicinal chemistry is a lot more complicated. It's not as easy to do. And so there are multiple different, and it'd be interesting to see how this pans out. This is a slide that was presented at AACR in 2024, this so-called RAS-on inhibitor. This drug crosses the cell membrane and binds a cellular protein called cyclophilin A, forms a binary complex. That complex can either form covalent or non-covalent bonds with a KRAS mutation, whether it be KRAS G12C, D, or a multi-KRAS, or any KRAS mutation, so more KRAS G12X, you could even say in some cases. And already we've seen a lot of very interesting data for this, particularly around pancreas cancer. I think as expected, we've had some challenges with colon cancer for a number of reasons, probably related to what I just showed you around the heterogeneity of resistance, the need to pair it up with an EGFR antibody. But already there's some interesting data that shows you can pair these RAS-on inhibitors together and maybe rescue a patient who's developed acquired resistance to a KRAS G12C RAS-off inhibitor. So this is data that was shown at AACR, looking at how patients who had progressed on prior KRAS G12C could actually respond to a combination of a pan-RAS inhibitor together with a KRAS G12C on inhibitor. So very interesting, little inkling that maybe we've got something here, but it will take years, I think, to build that story out. So how do I treat KRAS mutated colon cancer? It's the first step before you do anything is test your biomarkers. You need to know your MSI, your HER2, your BRAF, your NRAS, your KRAS status. If there's a KRAS mutation, right now we're doing first-line chemotherapy and bevacizumab. If you've got a KRAS G12C mutation, Would love to put them on a trial. They're hard to find. But at progression, then in the second line setting, this is where I like to think about my targeted therapies, whether it be adagrasib Sutux, sotorasib panitumumab. And then if they have any other RAS mutation, I would say find a trial center, get that patient on a trial. Sometimes as early as second line, there are some options for drugs that target KRAS G12D, V, and others. But if you don't have access to a trial, then it's chemotherapy and bevacizumab as well. So I think the future's bright. I'm very positive about targeting KRAS. We know KRAS G12C. We've cracked the code. We know if we pair them with an EGFR antibody that we can have another tool in our armamentarium, which is exciting. But we know that resistance will be inevitable in these patients, and we need to be thinking through to what's next. I think that's exciting. We're starting to see some hints that there are some new therapies and new strategies on the horizon for that resistance. And so that's why I'm staying positive here with this. Now I want to switch over to HER2 positive metastatic colorectal cancer. And this is something that's been near and dear to me, and I know you as well, Dr. Lenardi, over the years. So where does HER2 fit in this diagram of the genomic landscape? In general, HER2 is associated with RAS wild-type disease, but about a quarter of patients will have also a concomitant KRAS mutation. And that's important. It's something to keep in the back of our minds as we think about the optimal strategy for these patients. It's found in about 3% of colorectal cancer, which ironically is the identical percentage of KRAS G12C. It's typically on the left side, but it can be on the right. We think about HER2 being very heterogeneous in expression in the gastric upper GI tract, gastroesophageal cancers, not so much for colon cancer. We'll see more homogeneous expression. And I don't know, well, maybe we'll talk about whether it predicts resistance to anti-EGFR therapies later. Well, I put a question mark next to that, a little bit controversial. But I think one of the interesting things about HER2 is that it is strongly associated with brain and lung metastases. There's a classic pattern of metastatic disease with these patients. So, now we've got a wealth of options in the clinic. We've got a lot of different ways we can target HER2 positive colon cancer. So I'm actually going to break up this talk in terms of classes of therapies. The first class are the anti-HER2 tyrosine kinase inhibitors. These have some strengths. They're oral. They cross the blood-brain barrier, so you can get some CNS penetration. We've got a lot of choices in the clinic. And I think in general, while there is known toxicity, the rate of severe toxicity is rather low. However, it requires a compliant patient who you can trust with taking medicines. There are some molecules, and I'll go into this in a bit, that have lower selectivity for HER2, or they might hit other proteins in the HER axis, and that can cause some diarrhea and rash. Also, these are therapies that need intermediate to high levels of expression. So this is HERACLES-A. We can thank the Italians for bringing HER2 into our clinics. This was the first attempt to target HER2 positive colon cancer. Here they looked at patients who had chemotherapy refractory disease, KRAS wild type, treated them with a combination of trastuzumab and lapatinib, and now with long-term follow-up, 28% response rate, PFS at 4.7 months. Great therapy. It landed in our NCCN guidelines based on this initial experience, and we were all thankful to our colleagues from Italy. But we knew that there were new treatments coming in the clinic. This is something that I had spent some time exploring as well. And one of the therapies that intrigued me was tucatinib. And if in that little box in the upper right-hand corner, you can see the IC50s. One of the things you'll note is the IC50 is very low for HER2, which means it's very potent against HER2, but that number is very high for EGFR, which means it doesn't target EGFR very much, which means that you will get some of that, you'll get theoretically at least less of that diarrhea and rash that can be a problem with, say, lapatinib and neratinib. One of the other interesting findings about these therapies is they don't really work that well by themselves. So trastuzumab, the antibody, tucatinib by itself, modest activity, but when you put the two together, synergistic killing, and you can see that in these three patient-derived xenograft models shown here. So that led to the Mountaineer trial. So we designed this for second-line metastatic colorectal cancer, RAS wild type. All the patients had received prior 5-FU, oxaliplatin, irinotecan. We did not require prior anti-EGFR therapies. And we said, but you could not have had prior anti-HER2 therapy. Based on the success from cohort A, the study was expanded. And as per the request of the regulators, we actually did a randomization between tucatinib, trastuzumab, and tucatinib, with the primary endpoint being response rate in cohorts A and B, that combination. So these are the results of from the long-term follow-up from the Mountaineer trial. This is a median follow-up of 32 months. On the left, you can see a table just kind of cataloging the key efficacy endpoints. 39% response rate. Duration of response was incredibly long at 15 months. Progression-free survival also impressive at 8.1 months. And then you can see in that spider plot on the right, we had patients that have had deep, durable responses for literally years on this study. So very exciting for our patients. And I'll tell you, if you're going to be stuck on an anti-cancer therapy for 5 years, let it be one that's highly selective for a target with minimal side effects, so you can have your quality of life as well. So this has been a major victory for our patients. As mentioned, and this was my hope when it was designed, that we'd have less of the toxicity that can plague patients sometimes with these tyrosine kinase inhibitors. So the blue in these bars is grade 1, 2, so mild, moderate toxicity. The orange is grade 3 or greater. And you really have to squint to see the orange here. We do see diarrhea and fatigue. It's typically grade 1 and 2 and very easy to manage in most cases with just Imodium as needed. So once again, a victory for the patients to have that tolerability. So that's not the only class we have. We have the antibodies as well. And these have strengths. They are excellent compliance, because when that patient goes there, you know exactly what they're getting. I'd say low rates of serious toxicity, generally well tolerated, very specific to the target. But the key weakness here is that they do not cross the blood-brain barrier. So you can see central nervous system failure with this class. We see low rates of cardiotoxicity, and once again, you need intermediate to high levels of expression. There are 2 major antibodies that I consider in this class that are available to us in the clinic. One is trastuzumab, which has been around for decades, is off patent. The other is a new one that I'll mention briefly, zanidatamab. And pertuzumab, sorry, I should have mentioned that one as well. So we have extensive data looking at the trastuzumab-pertuzumab combination in the clinic. I will just summarize this by saying that we know now from multiple different trials conducted around the world, the response rate hovers right around 30% or so, and the progression-free survival is in the 3 to 4 month range. And so that was an important breakthrough that is on our guidelines right now. It's not FDA approved. And then there is a new drug in the clinic, recently approved for HER2-positive biliary tract cancers. This is zanidatamab, which I think is kind of a fancy trastuzumab-pertuzumab. It's a bispecific antibody that binds those same receptors, but I think it's doing something more. They published a very nice response rate in colorectal cancer at 38%, with a progression-free survival at 6.8 months. So this one is not approved for colon cancer, and it's not in our NCCN guidelines, but it is something that could be considered based on a pretty robust data set here as well. And then finally, the class that we all talk about as well is the so-called antibody-drug conjugates. These are standard antibodies like trastuzumab linked to a cytotoxic payload. The one we're most familiar with, at least in the GI world, is trastuzumab deruxtecan, which is a topoisomerase 1 inhibitor. This has some strengths. Once again, single IV infusion, activity, not in colon cancer, but in certain other tumors and lower intermediate expression. And it's got that pan-tumor approval. So you just need to see IHC3+, and then you can use that. It's within label. But it has some challenges. It's got toxicity that's more akin to chemotherapy, and then there have been some fatalities related to pulmonary toxicity. So I will go as quickly as I can through this data so we can talk about it a little bit more. But DESTINY-CRC01 was the first foray into this. This took patients second line or later, HER2-positive colon cancer. All patients were HER2-positive by central confirmation. They allowed prior anti-HER2 therapy, and this had 3 cohorts: high, intermediate, and low. Key thing to note, intermediate and low were closed due to lack of efficacy. They didn't explore that any further. Cohort A, which is the classic HER2 positive group, that's where we've generated all the data for colon cancer. Confirmed objective response rate in this study was 45% with a PFS at 6.9 months. Interesting lessons from this. First, HER2 status, IHC expression matters for trastuzumab deruxtecan. Only one response out of 13 patients for HER2 positive, IHC2 plus, FISH positive. Mainly these responses are concentrated in IHC3 plus. And another really important note, this drug works just as well whether or not a patient has had exposure to a prior anti-HER2 therapy. The main issue with this drug, at least in DESTINY-CRC01, was pulmonary toxicity. There were 9% of patients had some form of ILD or pneumonitis, and there were 3 fatalities out of 86 patients. So that led to this DESTINY-CRC02 dose optimization study. Patients randomized, once again, same group of patients, refractory colon cancer, HER2 positive by central review, randomized to the lower breast dose of T-DXd or the higher gastric dose, 6.4 mg per kg. And I would say the bottom line here is response rate was numerically better with the lower dose. Progression-free survival almost identical between the 2 doses. And most importantly, toxicity improved by taking that lower dose, the 5.4 mg per kg. So if you are going to give trastuzumab deruxtecan for a patient with colon cancer, make sure to use the approved dose at 5.4 mg per kg, not the gastric dose. Also, just as we saw with DESTINY-CRC01, IHC expression level matters. Once again, only one response out of 18 patients where it's 2 plus FISH positive. Almost all the responses were seen in patients who had IHC3 plus disease. Another point that's very interesting, you can respond to this even with a RAS mutation. So we know that that's an option. And once again, did not matter whether a patient had progressed on prior anti-HER2 therapy or not. And so we've got 2 FDA-approved therapies for colon cancer. We've got tucatinib trastuzumab, approved in January of 23. And this is for patients who have RAS wild-type, HER2-positive disease by any local test, NGS, IHC, and FISH. And then we've got trastuzumab deruxtecan approved based on an IHC of 3+. That was a more recent approval. So how do I treat these patients? Check the biomarker, get it quickly. If they're HER2 positive, right now I'm doing chemotherapy and bevacizumab first. There is a first-line trial. I'd love to put the patient on the first-line trial if I could. But if they're RAS wild-type, I would start with tucatinib trastuzumab, hold trastuzumab deruxtecan in reserve. If they've got a RAS mutation and they're HER2 positive, I move straight to trastuzumab deruxtecan in that chemotherapy refractory setting. Okay, so HER2 is an actionable target. We need to be testing everybody for this because we've got FDA-approved options. And I have found these to be highly active for patients and a game changer. So I like to start them as early as second line, not make that patient wait for this therapeutic class. So let's go on to the case. This is Caroline. This is a 68-year-old patient with a new diagnosis of unresectable metastatic colorectal cancer. And NGS captures a KRAS G12C mutation. And so, Heinz, maybe I'll start with you on this. You've got this patient. You see a KRAS G12C mutation. What are you thinking about here?
So I think it's very important to note the G12C mutations are more resistant to chemo than any other KRAS mutation. So chemotherapy, which is usually the standard of care in first line following the approval, I've tried to put her on our trial with the first line G12C cetuximab and the backbone chemo, if possible. Otherwise, I probably would do a FOLFOXIRI Bev and then do the combination of G12C inhibitor with cetuximab.
So Dr. Lenardi, I'm going to switch it up a little bit for you because you're an expert in this area.
Also because you know that I would have responded FOLFOXIRI Bev.
Say it again.
I would have say FOLFOXIRI Bev like you.
We are the same page.
Yeah. So what if this patient had RAS wild-type HER2 positive disease? What would you give? How would you approach a patient like that in your clinic?
Clearly, I'm very jealous because in Italy we don't have the label for HER2 inhibitors. We have the Mountaineer 03 trial open, and so obviously, if I can, I screen the patient for the trial. But if I don't have the trial open, the impact, as you said, as resistant element, resistant alteration to EGFR inhibitors is a bit shaky, because all the data came from monotherapy in late line and not from first line. So you didn't specify, but we know that HER2 amplification is more common in the left-sided primary tumor. And so actually, I would not consider HER2 amplification in my choice if I don't enroll in a trial. And if the primary tumor location is left-sided and obviously wild type, I will treat with a doublet plus EGFR inhibitor. While if it's a rare right-sided primary, HER2 amplifier RAS wild type, super rare, but I would go for FOLFOXIRI-BEV. And then I will try to give them as an off-label use, unfortunately in Italy, HER2 inhibitors in second line.
And that may be where the U.S. practice might be slightly different. We're less prone to the anti-EGFR therapies in this type of setting.
Well, I think that you can also choose FOLFOXIRI-BEV, because all the data that we have says that in the left-sided wild type, FOLFOXIRI-BEV or doublet plus EGFR inhibitor are more or less similar efficacious. But you know that doublet plus BEV in left-sided RAS wild type is slightly worse than the other two options.
I follow your approach in that I would give FOLFOXIRI-BEV and just not have to worry about it. Yeah. And then I stay within label for tucatinib trastuzumab next.
Exactly.
Yeah. So we have answer this question on your device. You're treating a patient with relapsed metastatic colorectal cancer following therapy on upfront FOLFOX chemotherapy plus bevacizumab. Further evaluation reveals a KRAS G12C mutation. What are your next steps for this patient? You know that this was a little bit of a trick, because currently we know that sotorasib should be given with an anti-EGFR therapy, and that was a little quirk to that answer. So that's why that one is probably not.
But the data looking good for that.
Yeah, but that goes with panitumumab.
I know.
So that's why it's kind of a quirky answer there. But FOLFIRI chemotherapy plus Bev is also, I think, a reasonable choice as well.
But I think what was amazing to me when you look at the sotorasib chemotherapy combination, the molecular escape is completely different.
Yes.
So I think chemo is not off the table for this. So I don't think that's necessarily wrong. We run it. Today I maybe even choose the chemo, but it's early data. But it is a different mechanism of action. So, I will.
And I also would say that results of the Crystal-10 are not so obvious.
Yeah.
I'm not so sure, because we know that in GI cancer, targeted treatment work better with chemo.
Yes.
When we use targeted treatment alone, sometimes we are disappointed. So I obviously hope that the Crystal-10 will be positive, but I'm not sure that the result is obvious.
So next question here is, a patient is presenting with HER2 positive. In this case, it's IHC2 plus, FISH amplified, and RAS BRAF wild type, but it's a right-sided tumor. How would you now proceed with treatment for this patient? We have cetuximab or panitumumab plus chemotherapy. Dr. Lunardi, I'm curious how you would proceed with this patient. If you had access to
I think that for now, between these choices, the stronger data are for tucatinib and trastuzumab, probably. In my clinical practice, have to ask for an off-label use of HER2 inhibitors, and I ask for tucatinib and trastuzumab as off-label use. Trastuzumab deruxtecan has strong data, but for now it seems that they are not investing in more development in colorectal cancer, and so probably because the population is really small. I think that the only one that for me is not in my thought is cetuximab or panitumab plus chemo. I don't think, because it's a right-sided tumor. Okay, let's assume that this is a refractory setting and tumor location is not so strong in the refractory setting, but clearly I would prefer to go for HER2 inhibition.
I think every single answer here has problems, right?
Yeah.
I mean, we know this is not the ideal setting for an anti-EGFR therapy, given that it's right-sided, it's HER2 positive. Trastuzumab deruxtecan, this is outside of the label because the odds of a response are incredibly low.
And immunohistochemic
Right,
2
yeah.
plus is not the preferred setting.
Really, the only one that's truly within label in this setting is tucatinib trastuzumab. And granted, the response rate's lower for tucatinib trastuzumab in this setting, but actually 20% response rate for 2+ FISH positive. That surprised me from the Mountaineer study, how well these patients with more intermediate levels of HER2 expression did. So yeah, that would be my choice.
And you can always give trastuzumab deruxtecan after that.
Yeah.
Yeah.
All right.
So also because some of the concept we spoke about, the RAS inhibitors, are really similar. Speaking of, as I said, now we are looking at another driver that is BRAF mutation. When we speak about BRAF mutation, we commonly refers to the D600E mutation, that is the widely more frequent alteration of BRAF. And, this protein is downstream EGFR receptor activation. But compared to other diseases like melanoma, and as John already said about KRAS mutation, in what we saw in colon cancer is that it's not sufficient to inhibit B600E mutated BRAF, because you have other collateral pathway, and so you need to inhibit in multiple point all the pathway. One important thing is that BRAF mutation is associated with distinct clinical features, both from the patient perspective. They are often women, older age. You have specific tumor characteristics like tropism, the attitude to spread to the peritoneum and the lymph node, a right tumor location, as we already said, and you often have a poorly differentiated tumor, mucinous histotype. And from the molecular point of view, I think that the more important thing is the association with the microsatellite instability or a deficient mismatch repair tumor. More or less, to keep in mind, 1/3 of BRAF mutated tumor are also MSI high, and 1/3 of the MSI high are also BRAF mutated. And so to make it simple. And when you have a BRAF MSI high, please keep in mind that the important thing is MSI high. So forget about BRAF if you have also an MSI high tumor. Obviously, the strong negative prognostic value is well known since years. This publication, I decided to put this one of 2009 just to show that we know in a long time the prognostic effect, but for a long time we weren't able to inhibit the target until we had obviously before Beacon, some smaller trial, and then we saw that inhibiting with encorafenib plus cetuximab plus or minus binimetinib was tested against a control arm that I can say it was a bit controversial at that time, but we don't have time to go deep into this. And in this randomized trial, it was second and third line, so refractory setting, but different lines of treatment. The trial was clearly positive, and as you can see here, it seems that binimetinib was not adding too much, and it increased the toxicity, as you can see here, and so actually not having an important advantage. The advantage was only in response rate, but not in overall survival nor PFS. And so taking into account the incremental toxicity of the triplet, the triplet combination was not developed further. And the data coming from the Beacon were confirmed also in the real world setting in multiple trials. And so we can say that encorafenib plus cetuximab became the standard of care in second and third line BRAF mutated tumors. And all the trial showed that they are working better in second line. And so my main message is that in clinical practice today, for a BRAF MSS tumor, encorafenib and cetuximab combination is the standard of care in second line. I don't see a reason to postpone them in third line. You can go for standard treatment in first, enco chet in second, and then you still have probably the other doublet. Clearly, we know from a previous history of colon cancer, like with EGFR inhibitors, that the sooner you hit the target, the better it is. And so the ANCHOR trial tested encorafenib, binimetinib, and cetuximab in first line. The results were interesting, but in the next step of development of the phase 3 breakwater trial, the decision was to bring only encorafenib and cetuximab and to combine them with chemotherapy. Obviously, at the beginning, there were a small safety lead-in phase with FOLFIRI and FOLFOX combined with ENCOCHET, because clearly we did not have any data on the combination with the chemo doublet. And then after verifying the feasibility of this combination, the phase 3 part of the trial started. The main trial was only with FOLFOX. Actually, as investigators, we was not so satisfied about the choice of developing only the combination with FOLFOX. It was based on some pharmacokinetics data, but without any clinical relevance in terms of efficacy and toxicity. So the trial completed the enrollment, and then another additional cohort was open to develop the combination with FOLFIRI. So basically we had the safety lead-in multiple lines, and then first line with FOLFOX, and then first line with FOLFIRI. Please pay attention, I think it's important that the target therapy only arm, the arm A, ENCOCHET, was closed due to futility of the treatment. And that's why we always say, okay, and like Joseph said, chemotherapy still has an important role, even when you have a biomarker and even when you have the proper target therapy. These are the data we already have coming from the safety lead-in part of the trial, more or less 30 patients per arm. and in first line, they were 19 and 12 with FOLFOX and FOLFIRI. I think that these data were really, really reassuring on toxicity and also promising on the activity and efficacy point of view. And so the trial went on. You already heard that we are going to present the Checkmate HHW and also the preliminary result of the Breakwater first line part of the trial. So from my enthusiasm, you can understand that my expectation is positive. As I said, forget about BRAF if you have an MSI high, but don't forget completely, because the CMARC trial just closed the enrollment, and obviously the main treatment, as I said, is immune therapy, and so you can see that the control arm is pembrolizumab, but here we are investigating pembro plus Encosette to see if having BRAF inhibition together with PD-1 inhibition can improve the outcome. Obviously, I don't know what we will think about the problem of the immune doublet, because here we could say that we have a control arm that is underperforming compared to the new standard that we are gonna have soon. But anyway, we will try to interpret the result on the basis of what's coming on. So just to close the BRAF story, for now, Encosette is the standard therapy in second line, a chemo-free regimen, but soon I think that we are gonna treat patients with chemo plus Encosette in first line. And we will see what about the BRAF and MSI high concomitant alteration. But what are the other treatment options in later line? This was the paradigm of treatment before 2023. We had trifluridine tipiracil and we had regorafenib, more or less same efficacy, completely different toxicity profile. But anyway, we got used to start with one of those and then reverse. And there were no major evidences of that one sequence was better than the other. But that was true until we saw the result of the Sunlight, the phase 3 trial comparing in the refractory setting trifluridine tipiracil with or without bevacizumab. And I have to say that I was really, really surprised by the result of this trial because, previously bevacizumab didn't show major improvement in late line. And so I think that no one would have a bet on curves like this and on an hazard ratio for overall survival of 0.61 is really high, unexpected for me, I have to say. But I think that the trial is really, really clean. The results are reliable, in my opinion. And so I believe that we can easily say that in the metastatic colorectal cancer without oncogenic driver, trifluridine tipiracil plus bevacizumab is the preferred third line. Clearly, we had other drugs coming, and we developed and we saw the result of fruquintinib, a selective VEGFR1-2-3 inhibitor. It's not really, it's similar to regorafenib, but not the same. And the trial I'm referring is the FRESCO-2 trial, fruquintinib versus placebo. in late line. And pay attention that all the patients enrolled have to previously received trifluridine-tipiracil or regorafenib or both. And so we are really in a late line setting. The trial was positive and was positive in every outcome we tested. Here you see the primary endpoint, the overall survival in the intention to treat population. Tomorrow I will have a poster showing then that even adjusting for the subsequent line of treatment, the benefit in overall survival for fruquintinib remains. And so the drug was approved. This is the PFS, very typical shape for PFS in the refractory setting. And the efficacy was seen irrespective on the line of treatment and irrespective of the previous treatment with trifluridine-tipiracil, regorafenib, or both. So how can we choose what to do? Because now we see here trifluridine-tipiracil plus BEV, and then fruquintinib or regorafenib, and the reverse. Why I and Filippo Pietrantonio decided to put fruquintinib before regorafenib? Just because it's slightly better tolerated in our experience. With fruquintinib, you have a little more hypertension compared to regorafenib, where you have a little more hand-foot syndrome. But from the patient perspective, hand-foot syndrome is more impacting quality of life compared to hypertension. And usually you can easily treat hypertension just adjusting the concomitant medication, while it's really difficult to treat a bad hand-foot syndrome. And so my preference goes to this kind of sequence, but obviously having regorafenib after trifluridine-tipiracil and BEV is equally correct. And then, and here I'm putting all we heard from John in this perspective. Clearly, if we have an oncogenic driver, we have to consider if we didn't use before to start, to the possibility to start targeting the driver, and then all the other drugs. We really don't know which strategy is the best. We do not have any real head-to-head comparison. But as I think we are going to put targeted therapy with chemo in first line, probably we are not going to have this the last part of the picture in some years, and so probably we will go to the target before, and we will use the sequence trifluridine BEV, and then the others in the late line. So this is the case. We have William, 70-year-old patient with metastatic colorectal cancer, progressed after multiple line, no biomarker, ineligible for immune therapy. And if you are thinking, okay, if it's not MSI, why you are specifying this? Because there are some trials with other immune therapy in MSS in late line, but is not eligible. So based on what we said, which are your preferences?
I think I would do the sunlight, the TAS 102 with BEV. That's the third line.
Yeah, we have three options now. Just as you said, we've got fruquintinib, we have TAS 102 plus bevacizumab, we've got regorafenib, and ultimately we have outstanding data from sunlight. This is really the sunlight setting. We see great data. So if the patient can tolerate and we think they'll do well with that regimen, we would certainly consider that. There are scenarios where we might alter that sequencing, maybe if the patient has severe myelosuppression or there's some concern for the cytotoxic, but in general, it'd be TAS-102 plus Bev.
Great. And how do you, are you scared about hematological toxicity of trifluridine-tipiracil in late line? Or
Not really.
Not really.
Not really. I mean, they maybe get a little bit anemic. I don't see really significant neutropenia requiring any intervention, but I have not seen any major. You see the numbers going down without any particular impact. Do you see that?
It's not been a major problem.
No.
I mean, it actually interestingly is associated with clinical benefit from.
Yes,
Yeah, exactly.
So you actually want to see a little bit of neutropenia. There are various ways to manage that, whether it be dose reductions. Some people I've heard increasingly are changing it. So instead of Monday through Friday, the first 2 weeks, I've heard of people doing it every other week.
Yeah.
And that
I actually do that now.
Yeah?
Yes.
So
Kathy's study. Yeah.
yeah. So that may be a way to combat that neutropenia and maintain still the dose intensity.
So we will have a couple of minutes to do some question and answer. So there is a question. Oh, that's a good one. What do you believe is the cause or driver for colon cancer in younger age groups? We recently had a 19-year-old diagnosed with stage 3 colon cancer.
This is a question that plagues our clinic. We've seen a doubling of the incidence of colon cancer in people under 50 over the last 30 years. It's becoming a public health crisis. It's challenging because colonoscopy screening only starts at age 45 in the United States. So these people are coming in. They're oftentimes ignored by their primary care physicians when they describe blood in their bowel movements. So they can sometimes present with quite advanced disease. We don't know the answer. There are a lot of theories out there, very difficult to prove at a population-based level. In my gut, I think it's, no pun intended, in my gut, I think that it may be something people are not exposed to anymore that they were maybe exposed to in the hundreds of years ago, right? But it's just a guess. Sarah?
I don't have too much to add because we don't know really the reason. I think that obviously we have to screen for Lynch syndrome, but even if you don't have Lynch syndrome, if you have a young patient, I suggest to refer him to the genetic consultation, because you know that there are also other alteration, really rare. We had one with a MUTAH.
MUTAH, yes.
Yes, mutation. So they are not common, but if you have a young patient, I think that it's mandatory to have a genetic evaluation.
I agree. So we have a moonshot grant because the minority with the highest incidence or increase of early onset is Hispanics. So we have 16, 18, 20, 22-year-old. And this look like high school students, athletes. They don't have obvious risk factors. And there is no genetic predisposition. We are all screened with all the genes. So what can it be? Oh, can it be metabolic? They're almost too young. They're almost too young. But there are some interesting stories for cardiac disease. So you have higher risk for cardiac disease if your parents had cardiac disease. You know that, and it's not necessarily a genetic.
Yes.
It's an epigenetic. So we have now doing a lot of epigenetic regulation in this to identify if potentially silencing of genes of the parents transformed to the kids can cause that. So no one knows for sure, but it's certainly not genetics. There is another question. Sarah, for you probably, is there any patient characteristic that help you choosing between fructitinib and regorafenib?
No. Quick answer.
Okay. Another good one. There are a lot of good questions. I don't know. You need more gift cards. How do you manage patient with advanced microsatellite stable colorectal cancer with a pathogenic POL-E mutation?
Yes. So yes. Great question. These patients with pathogenic polymutations can generate huge tumor mutational burden, sometimes in the several hundred range. So our standard would be to give an anti-PD-1, an immunotherapy strategy. You might go for Ipi-Nivo, I guess.
Absolutely.
Yeah.
Yes, the
But,
sooner the better.
yes, absolutely. I consider that actionable with immunotherapy for sure.
But the most important was the pathogenic, okay?
Yes.
Because the non-pathogenic, it would not work.
So you know it's pathogenic because they have a high tumor mutational burden.
In fact, when you see TMB of 100, you know it's a polymutation.
Yeah.
Okay. I think this will be our last question. This is from the webcast. The bot is another CTLA-4 agent being developed in colorectal cancer. What do you think of CTLA-4 as a target, and what is it doing to the immune population? Are there any other combination with CTLA-4 that makes sense?
Well, we are going to see tomorrow some data on the trial with Balbot. And data we have for now in the MSS population is that they are active and in the specific population without liver mets. So I think that CTLA-4 inhibition is still important, and we know that this is true for MSI-high and for MSS. But, you know, companies try always to find other TIGIT inhibitors, LAG3 inhibitors. But I have to say that I had the impression that the combination between PD-1 and the CTLA-4 is still better than any other immune combination for now.
Let's finish up with one more, because I like the question a lot, because it's really an ongoing discussion. So with chemotherapy using fluorouracil, do you pre-test for DPD deficiency before you treat? Why or why not?
Well, in Italy it's mandatory. And obviously we strongly believe to DPD importance, because it's a very easy test and you can spare an high toxicity to the patient. If you have heterozygosis, you can reduce the dose. Obviously, in the rare cases of homozygosis, you cannot treat with fluoropyrimidine. I think it's really important to test for DPD before starting fluoropyrimidine. Right. And also because now with the trifluoridine-tipiracil or S1, you have an alternative.
Absolutely. Okay, so I think we are at the end. I would like to thank every one of you coming tonight, because it's a long day. I hope you had at least some fun listening to us and learned something and enjoyed this evening. Thank you so much. And we will see each other again during the meeting, or hopefully next year. Let us know how you felt and how you experienced the meeting. And thank you to my Dr. Lonardi and Dr. Strickler. And have a good night, okay?
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Colorectal Cancer Alliance. This activity is supported by educational grants from Bristol Myers Squibb, Pfizer, and Takeda Pharmaceuticals U.S.A. Incorporated. To access all materials for this activity, visit peerview.com/UCS860.